Okay, so good morning again. So we're gonna do Doppler echocardiography this morning. The different areas we're gonna concentrate on is the Doppler effect. What is the Doppler effect? The Doppler shift formula, spectral recording, what they look like, and how to draw them. Uh, then we're gonna discuss pulse wave Doppler, PW, continuous wave Doppler, CW, and then color flow Doppler. So these are the different areas in Doppler that we're going to look at. And you're encouraged to read up more and to increase your understanding of Doppler. So when we say Doppler, what are we talking about? So the Doppler effect was first proposed by an Austrian physicist named Christian Doppler in 1842. And he essentially just made an observation and proved his observation. So you all must have recognized that if there's a moving source of sound, if something is moving, say for instance, a car and the horn, someone is pressing on the horn in the car and the car is coming towards you, there is a you perceive that the intensity or the intensity increase, and then as soon as the car passes you and is going away, the intensity of the sound decrease. That is essentially the Doppler effect. So when we talk about the Doppler effect, it's a moving source of sound. So you have to have sound wave, that is, and the sound wave have to be moving. So is either it coming towards something or going away from something. So if the sound wave is coming towards, say, you, an individual, okay, it's moving towards you, you're going to perceive that the intensity or the frequency is increasing. And as soon as it moves away from you and it's going away, you're going to perceive that the intensity or the frequency is decreasing. So that is the basic principle of the Doppler effect. Okay? Moving source of sound coming towards you, and the most common example is a car and the person driving the car is blowing the horn. When the car come towards you, you perceive that the intensity of the sound is increasing. And then as soon as it moves away and it's moving further away from you, you perceive that the intensity of the sound is decreasing. Okay? So uh, it is not too difficult to understand that those principles, but those are the Doppler principles, and you have to remember that. So the Doppler shift, again, when an object is moving towards the transducer. So remember, even though we use an everyday life experience, when we're talking about ultrasound, we have a probe or a transducer, and you can have movements towards the transducer or movement away from the transducer. Again, you can have movement towards the probe or movement away from the probe. When we do echocardiography, we use or transducer probe to look at the heart, and a number of things happens. You'll have blood flow towards the transducer. Sometimes you're going to have blood flow away from the transducer. Sometimes you're going to have the tissue, the heart itself, because remember the heart contracts and it does all sorts of different motion. So sometime the tissue of the heart, the tissues of the heart is going to move towards the transducer, sometimes it's going to move away from the transducer. Okay? So when an object is moving towards the transducer, the frequency observed is higher than the transmitted frequency. So let's analyze that statement and fully understand that statement. Just like when the car with the horn going is coming towards you, if you analyze everything that's happening there, someone is blowing the horn, the frequency of the horn doesn't change. If I'm blowing the horn and I keep, usually when you're blowing the horn, you keep the frequency the same. You're not going to say, okay, I'm approaching that person, let me increase the frequency of the horn. No. The frequency at which you blow the horn is going to be the same. But what's happening, the person who is observing the moving source of sound is going to perceive that the frequency is increasing, even though the actual frequency is not increasing. It is the perceived frequency. The person is perceiving that the frequency is increasing, but the person in the car that's blowing the horn is keeping that frequency the same. So the frequency observed by the person who is standing is higher than the transmitted frequency. And similarly, when you do your ultrasound and say you put your probe on the chest, when blood moves towards the transducer perceives that frequency to be increasing. Okay? And then when an object is moving away from the transducer, the frequency observed is lower than the transmitted frequency. So what we're saying, when we do ultrasound, the frequency that we're sending out from the transducer or the probe is going to be fixed. Say 2 megahertz. We're sending out 2 megahertz. But if you have blood flowing towards the transducer, the transducer is going to perceive that frequency, say 3 or 4 megahertz. It's going to perceive a higher frequency. When the blood is moving away from the transducer, even though you're doing your ultrasound and you do your ultrasound at say 2 megahertz frequency, the perceived frequency from the probe is going to be reduced. Okay? So when an object moves towards the transducer, the perceived frequency is increased, and then when it moves away, the perceived frequency is reduced. The transmitted frequency is usually fixed. That is, if you're doing an ultrasound on a patient and you use 2 megahertz, that transmitted frequency is gonna be fixed. Okay? It is the observed frequency or perceived frequency which is gonna vary. The transmitted frequency is gonna be fixed. All right. All right. So when we construct the Doppler shift formula, there are a number of things that we talk about the Doppler shift. So it is the difference between two frequency, and the frequency we talk about a received frequency and a transmitted frequency. So remember now, when you do ultrasound, your transmitted frequency is gonna be fixed. It is received or perceived or observed frequency which is gonna vary depending on the movement of the structure you're looking at. Similarly, if you're standing in the road and a car with the horn is coming towards you, in the car, the transmitted frequency is going to be fixed, but you standing right there is going to receive the frequency as increased or decreased, whether the car is moving towards you or moving away from you. So the two frequencies that you have to concentrate on is the transmitted and the received. The transmitted frequency is usually fixed, and the receive frequency varies depending on whether the object, the moving source of sound is moving towards you or moving away from you. Similarly, the transducer, if it's moving towards the transducer, then the receive frequency is going to be increased. If it's moving away, then the receive frequency is going to be decreased. And so the Doppler shift is the difference in the receive frequency and the transmitted frequency. It's a shift. Okay. Again, transmitted frequency is going to be fixed. When you're doing ultrasound of the heart, if you're using a 2 megahertz transducer, that frequency is going to be fixed. But the receive frequency is going to depend on whether the blood or the tissue is moving towards the transducer or moving away from the transducer. Okay, so when you're doing Doppler echo, you always have to ask your question, is the structure moving towards the transducer or is it moving away from the transducer? The thing you have to ask yourself is the structure, whether it is the tissue or the blood, is it moving towards the transducer or is it moving away from the transducer? If the blood or tissue is moving towards the transducer, then the receive frequency or observed frequency is going to be increased. If it's moving away from the transducer, then the received or observed frequency is going to be reduced. This is the Doppler shift formula, and you need to have a basic understanding. Okay, of course, we said that, or if you remember, your F naught is the transmitted frequency, which is going to be fixed. So your Doppler shift is 2 times the transmitted frequency times the velocity of the blood or the tissue that you're looking at minus the cosine of theta divided by the velocity of sound in blood. So this is the Doppler shift formula. So you have the transmitted frequency there, you have the velocity of blood or the tissue, you have the velocity of the sound, and you have the cosine of an angle. And the cosine of this angle is very, very important. So you need to have a basic understanding of the Doppler shift formula. You need to know the components, what parameters are in the Doppler shift formula. In the numerator, you have the velocity of blood minus the cosine of an angle, and we're going to go over this angle. And in the denominator, you have the velocity of sound in blood. The velocity of sound in soft tissue, everybody needs to know that, is 1540 meters per second. So when you analyze the Doppler shift formula, again, you have your probe or your transducer right there. If the blood is moving towards the transducer, the receive frequency increases. And we depict that by showing waves with short wavelength. So when the wavelength is shorter, then it suggests that you have increased frequency. So if the blood or tissue is moving towards the transducer, then the receive frequency, not the transmitted frequency, the receive frequency is increased. And that's depicted as decreased wavelength, okay, increased frequency. As opposed to when the blood or tissue is moving away from the transducer, the receive frequency is going to be decreased, and that's depicted as increased wavelength, okay, in the wave. So when the blood moves towards the transducer, the receive frequency is increased. When it moves away, the receive frequency is decreased. When you do ultrasound, you have your ultrasound probe on the patient's chest. There's going to be, and when remember, your probe, you're going to generate sound wave in the probe, and those sound waves going to travel in a straight line down to the tissue, and you usually have an angle between the ultrasound beam and the moving structure, in this case blood. So the angle between the ultrasound beam and the moving tissue blood, this angle is called theta. For you to get very accurate imaging, your ultrasound beam should be parallel to the blood flow or the tissue movements. You want to reduce this angle theta when you're doing any ultrasound study, because if you look at your Doppler shift formula, the cosine of 0 is 1. So you'll get your maximum Doppler shift if your angle theta is 0, because the cosine of 0 is 1. As opposed to if you're increasing the angle, if this theta increase, so if this angle is increased, say it's 90 degrees, you're vertical, you're perpendicular to the moving structure, then you have cosine of 90. Cosine of 90 is 0. So this is going to be 0. So you essentially you're not going to see any, you're not going to get any Doppler shift. So when you will not see anything on your ultrasound monitor if this angle is 90 degrees. In order to get very good imaging or accurate imaging, let's use accurate. In order to get accurate imaging, this angle theta has to be close to 0, because the cosine of 0 is 1. So you get your maximum Doppler shift if the angle theta is 0. And that is why when we talk about Doppler, we say that Doppler is angle dependent. Doppler is angle dependent. So you have to be careful when you're doing these Doppler studies, because if your angle theta is too large, then you're not going to get accurate reading. Okay? You have to try and reduce this angle theta. Angle theta has to be reduced. Okay? It has to be close to 0. That is, your ultrasound beam should be as parallel to the flow, whatever, is it blood or tissue. Okay? You want to get the angle theta close to 0. All right. Another important observation is that when you look at your spectral recording, spectral velocity recording, flow velocity towards the transducer, so if you have movement, whether it's blood or tissue, towards the transducer, and when you look at your recording, it is that velocity is displayed as a positive or upward shift. What we mean by that, when you look at the spectral spectral recording, that recording is going to be above the baseline, okay? Because you have an upward shift in the velocity. Remember, we said that anything moves towards the transducer, the received frequency is going to be increased. So that is displayed as an envelope above the baseline, and we'll show you what that means. As opposed to when you have flow velocity away from the transducer, it is displayed as a negative or downward shift in the velocity. And this is what we mean. Okay, so all right, you have your transducer in the patient chest. and you're looking at, say, the flow of blood. If blood is moving towards, or any tissue that's moving towards the transducer, this is our baseline. It's going to give you an envelope above the baseline. So you guys must have seen Doppler studies, and some of the recordings are above, some of the recordings are below. The recordings that are above tell you that there is movement towards the transducer. And then for those recordings that are below the baseline, it tells you that there are movement away from the transducer. So when you have movements towards the transducer, you're going to get a recording above the baseline. When you have movement away from the transducer, you're going to get a recording below the baseline. All right. So this is an actual study. This is the short axis at the level of the aorta. This is our probe. So when you have these studies, you always have to see what is going on. So this symbol represents your ultrasound probe or transducer, which is on the patient's chest. This is short axis at the level of the aorta. This is our tricuspid valve right here. And we have tricuspid regurgitation. Tricuspid regurgitation means that blood is flowing from the RV across the tricuspid valve into the RA. So blood is moving from the right ventricle across the tricuspid valve into the right atrium. So the blood is moving away from the transducer. The transducer is right here. The blood is moving from the RV across the tricuspid valve into the right atrium. So it's moving away from the transducer. This is our baseline. This is our ECG. And we have these envelopes evenly spaced below the baseline. Below the baseline. These envelopes are below the baseline. And they're below the baseline because the movement of blood is away from the transducer. Okay? That is why it's below the baseline. Not only that, it's below the baseline, but if you look at your ECG, you have systole, which is from the onset of the QRS to the end of the T wave, onset of the QRS, end of the T wave, onset of QRS, end of T wave. You have these systolic velocities, which is below the baseline, which is tricuspid regurgitation. So tricuspid regurgitation is a systolic flow. Once you look at your ECG, you know, from the beginning of the QRS to the end of the T wave, systole. So it's a systolic flow, which is below the baseline. And that is what tricuspid regurgitation in this view looks like, because you have blood flowing from the RV across the tricuspid valve into the right atrium. It's moving away from the transducer. Hence, this is our baseline right here. It's below the baseline, and it's a systolic flow. As opposed to this scenario, you have your apical four-chamber view right here. Your transducer is still right there, and this symbol represents your transducer. Your cursor is right here. Sample volume is right at the tip of the mitral leaflet. The sample volume is at the tip of the mitral leaflet. You have blood flowing in diastole from the left atrium across the mitral valve and into the left ventricle. In diastole, blood flows from the left atrium across the mitral valve into the left ventricle. And if you look, this is your baseline, okay? You see you have an envelope there, you have another envelope there, you have an envelope here, you have another one there, and it repeats itself. Your ECG is on top, Systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. So you see that these flow are diastolic flow. So in diastole, you have this flow repeating itself. Okay? Again, remember in diastole, the mitral valve opens and blood flow from the left atrium into the left ventricle. The blood is moving towards the transducer. Blood is flowing from the left atrium, across the mitral valve, into the left ventricle. The blood flow towards the transducer. Hence, the envelope is above the baseline, and the flow is in diastole, which is from the end of the T wave to the QRS. And there are two envelopes. If you remember what we taught in our physiology class was when the mitral valve opens, there is like a suction of blood from the left atrium into the LV, and you get what we call your E velocity. So this is your E velocity. Then you have somewhat equalization of pressure between the left atrium and the left ventricle, and you get what we call diastasis. And then the atrium contracts. The atrium contracts and add an additional amount of blood to the LV, and this is your A velocity. So you have your E velocity, a diastasis, your A velocity. Okay. Again, these envelopes are above the baseline because the flow of blood is towards the transducer from the left atrium, across the mitral valve, into the LV. The flow is towards the transducer. It's a diastolic flow, which is from the end of the T wave to the QRS. Okay, E velocity, A velocity. Again, we see our Doppler shift formula. If you, again, so you need to know what the different components. This is your transmitted frequency, which is going to be fixed. Okay. Your V is the velocity of your moving structure, which is whether it's blood or the tissue, and then your C is the velocity of sound wave in blood. Okay, so if you look at if you solve for V, which is the velocity of your moving structure, okay, then again we come to the concept that you need to get your ultrasound beam as parallel to the flow as possible. Cosine of 0 is 1. Cosine of 0 is 1. So you're going to get your maximum velocity if the ultrasound beam is parallel to the moving blood. If your angle is 0, that means the ultrasound beam is parallel to the flow. And that's when you're going to get your maximum Doppler shift or velocity. If this angle is 90 degrees, you'll have no Doppler shift. You're not going to see anything. So when an ultrasound beam is parallel to blood flow, theta, the angle theta is 0 and the cosine of 0 is 1. Thus you get maximum velocity or the true velocity. Doppler is limited by the angle, the angle theta. That is the limitation of Doppler. You always try to get ultrasound beam as parallel to flow as possible. You want to get this angle theta close to 0. When an ultrasound beam is perpendicular to the blood flow, then the angle theta is 90 degrees. Cosine of 90 is 0. Thus, the velocity will be 0. So if you're doing your Doppler and you're not seeing anything, you might be perpendicular to the moving structure you're looking at. So you're not going to get any Doppler shift or velocity. So always assess Doppler in multiple windows. And that is why when we're doing Dopplers, you have to use multiple windows because you want to get your ultrasound beam as parallel to flow. And no one window is going to give you that. So you, especially when we assessing patients with aortic stenosis, we always recommend you use multiple windows because you don't know before you start the study which window is going to give you the most parallel ultrasound beam to flow. So always assess Doppler in multiple windows to get the most parallel beam to blood flow and hence the maximum velocity. This is extremely crucial. Now we are going to look at the different types of Doppler signals. We have pulse wave Doppler, color flow Doppler, and continuous wave Doppler. When we talk about pulse wave Doppler, PW, uh, PW, we almost always start our analysis using PW, pulse wave Doppler. It measures the velocity at a single point. So what you're doing, you're sending out a signal, and then the ultrasound, the probe is waiting for that signal to return. So the transducer sends out a signal and then wait for the reflected frequency. That is pulse wave. So you send out a signal, okay, send out a sound wave, and then you're waiting for it to return. The problem with that, however, you can only measure flow of certain velocity, low velocity flow. With pulse wave Doppler, you can only measure low velocity flow because you're sending out a signal and you're waiting for it to return. So it is limited by low velocity. Once you have higher velocity, then you get something that we call aliasing, and we're going to discuss that. So with pulse wave Doppler, it measures velocity of blood flow at a single point. The transducer sends out a signal and then wait for the reflected frequency. The transducer is alternating between transmission and reception of the ultrasound wave. The limitation of pulse wave Doppler is the velocity. Okay? Remember, the function of Doppler is just to look at moving structures. If you don't have any moving structures, then you're not going to get any Doppler, right? If you have no moving structure, so the purpose of Doppler is to look at moving structures and get velocities, and from velocities, you can get gradients. So that is the importance. And then we can calculate valve area, we can calculate pressures, a lot of stuff using the Doppler. Pulse wave Doppler is limited by the velocity. Pulse wave Doppler can only measure low velocity, velocity less than 2 meters per second specifically. Pulse wave Doppler can only measure velocities less than 2 meters per second. So low velocity flow. Once you have higher velocities, you're going to get a phenomenon called aliasing. That is, once it's reached the maximum 2, say for instance you imaging something that has a velocity of 4 meters per second. Once it gets to 2, it's going to cut off that portion, and a portion is going to be on top and a portion is going to be on the bottom, because pulse wave Doppler can only measure up to about 2 meters per second. So if you have a velocity of 4 meters per second, it's going to cut off when it reaches 2, going to cut off that 2, put the 2 say on top and the other 2 below. Okay, so these are the velocities that we use pulse wave Doppler to measure, and you have to remember these. Okay, we use pulse wave Doppler to measure mitral inflow because mitral inflow is a low velocity flow. The left ventricular flow tract velocity, because this is a low velocity flow. Hepatic vein flow or hepatic velocity, hepatic vein velocity, okay, that's a low velocity flow. Tissue Doppler imaging, we use pulse wave Doppler. Pulmonary vein flow, we also use pulse wave Doppler. And tricuspid inflow, not tricuspid, not TR, tricuspid inflow. So these are low velocity flows, and we use pulse wave Doppler to measure these. Initially, you have to probably memorize it, but once you start doing your echo, it becomes second-hand nature because you know when you're going to use your pulse wave Doppler, and then you also know when you're going to use your continuous wave Doppler. So pulse wave Doppler, we use to measure low velocity flow, mitral inflow, left ventricular flow tract velocity, hepatic vein velocity, tissue Doppler imaging, pulmonary vein flow, and your tricuspid inflow. Again, we saw this before. Apical four-chamber here, cursor is right there. The sample volume is there. Your transducer is right up here. We have flow diastole from the left atrium across the mitral valve into the left ventricle. The flow is towards the transducer, hence we have the envelopes above the baseline. Okay, this flow is in diastole. You have your ECG. Everything is gated in echo. Diastole is from the end of the T wave to the beginning of the QRS. End of the T wave to the beginning of the QRS. So in diastole, you have these repeated flows. This is our E velocity. You have a diastasis, then your A velocity. Okay, it's a pulse wave Doppler measurement because it's low. If you look here, this is 1.2 meters per second. Remember, pulse wave Doppler can only measure velocity up to 2. This is 1.2 meters per second. Okay. Apical four-chamber view, your cursors are your probe or transducer is right there. Your cursor is right there. The sample volume is right there. This is our left ventricle. Left atrium is down there. You have blood in systole. You have blood flowing from the left ventricle across the left ventricular flow tract, across the aortic valve into the aorta. Okay, so blood is flowing from the LV across the left ventricular flow tract, across the aortic valve into the aorta. It's moving away from the transducer. Okay, your transducer is right there. The blood is moving in this direction. It's moving away from the transducer. This is your baseline. So you have these envelopes below the baseline. Okay, this is our left ventricular outflow tract velocity. Okay, it's below the baseline because the flow is moving away from the transducer. If you look at your ECG, these flow occurs onset of QRS to the T wave. So these are systolic flow. Okay, and that's what you expect. The flow across the left ventricular flow tract is a systolic flow. When the left ventricle contracts and force blood, the blood is going to move across the left ventricular flow tract, across the aortic valve into the aorta. It's moving away from the transducer and it's systolic. So it's below the baseline and it's systolic from the onset of the QRS to the end of the T wave. So your left ventricular flow tract velocity is measured using pulse wave Doppler. Okay, this is 1 meter per second. So anything up to about 2 meters per second, we can use pulse wave Doppler. Anything above that, we cannot. Okay, when we do hepatic vein flow, okay, remember hepatic vein flow, you use your usually use your apical four-chamber view. You have hepatic veins on either side of the left atrium. Okay, we don't have the 2D image, but the flow is away from the transducer. If we use this, our hepatic veins are going to be right there. Okay, Okay, the hepatic veins are going to be right there. Okay, so, okay, sorry, this is not, no, this is your pulmonary veins. Okay, that was the hepatic. Sorry about that. This is your hepatic vein. Sorry. So let me see if I can. All right. So your hepatic vein. Let's see. All right. We don't. Okay. So your hepatic vein, you have to do your subcostal view. You have to do your subcostal view to get your hepatic vein. Remember, the hepatic veins drain into the inferior vena cava. If you can just put it in your mind's eye, uh, the all right, let's see if we can draw it so as not to confuse you. So if this is so, our hepatic vein would be like this, and the hepatic veins are going to drain into the inferior vena cava, and then your inferior vena cava is going to drain into the right atrium. Okay, okay, and your transducer is going to be right here. So this is your transducer right up there. Okay, blood is going to flow from your hepatic vein into the inferior vena cava. So the blood is going to flow away from the transducer. Your transducer is right here. Okay. This is your liver right over here. So you should remember. Okay. Your liver is right here. This is your right atrium. This is the hepatic vein. And this is your IVC. Inferior vena cava. IVC. So the blood is flowing from the hepatic vein into the IVC. It's moving away from the transducer, which is right there. That is why it is below the baseline. Okay? There are two components. You have a systolic component and a diastolic component, and then an atrial reversal. So this is what your hepatic vein flow looks like. Okay? Systolic component, which is from the onset of the QRS to the end of the T wave. The envelope is below the baseline. So you have a systolic component, a diastolic component, and then we call this the atrial reversal. Okay? All right. So again, everything in echo is gated. All right. The reason why the flow is below the baseline because the blood is moving away from the transducer. Okay. All right. So now we come to tissue Doppler imaging. So not only the movement of blood, we can also look at the movement of tissues. If you remember in our physiology class, we said, so your probe is right up here. And if we look at, say, the mitral annulus, we have a medial mitral annulus and a lateral mitral annulus. In systole, the base of the heart moves up towards the apex. So if you have your probe, if you have your ultrasound beam if you have your ultrasound probe right here, okay, when this moves up, it's gonna give you a positive or a Doppler shift envelope, which is above the baseline. And when it moves downwards, it's going to give you a Doppler shift envelope, which is below the baseline. So this is what we have our tissue Doppler imaging here. Okay, okay. So in systole, this moves up to the toward approach the transducer. Again, your transducer is right there. So your medial mitral annulus in systole moves up, and that is depicted as a S prime. Move toward it's above the baseline. Okay, this is S prime, which suggests that what tells you really that the mitral annulus moves up towards the apex. Okay, and your ECG is on top. Systole is from the onset of the QRS to the end of the T wave. So you get this upward envelope in systole. And then in diastole, it moves downwards. You actually have two components in diastole. You have what we call the E prime and the A prime. Okay? So it basically tells you that the mitral annulus moves downwards. And we can do that for the medial mitral annulus or the lateral mitral annulus. Okay? The contour of the signals are the same. Okay? The contours of the signals are the same. That is, in systole, you get a S prime, and then in diastole, you get an E prime and an A prime. Okay? You can see that systole is from the onset of the QRS to the end of the T wave. Diastole is from the end of the T wave to the QRS. You have a systolic component, which tells you that the annulus moves up. Transducer is right up here. And then in diastole, you have two components. You have an E prime and an A prime because the annulus moves down. Mitral annulus moves down. Okay? Okay? Hepatic vein flow now. Not that pulmonary vein flow. All right. So when you have your pulmonary vein flow, you're gonna go through the same exercise. Okay? Same exercise. So once you understand Doppler, you just apply it to everything. So again, your apical four chamber, your prober transducer is right there. And remember, your pulmonary veins are on either side of the left atrium. Okay? This is your right and your left superior pulmonary vein. So you have one right there and one right there. Remember that blood is going to flow from the pulmonary vein into the right atrium, right? So when the blood is oxygenated in the lungs, the oxygenated blood is going to travel via pulmonary veins into the left atrium. So the blood is going to flow from the pulmonary veins into the left atrium and towards the transducer. So the blood is flowing towards the transducer. So you're going to get a systolic component, a diastolic component, and an atrial reversal. Okay? So in systole, again, everything in echo is gated. Okay. So from the onset of the QRS to the T wave, systole. From the end of the T wave to the QRS is diastole. So you have a systolic component, a diastolic component. So just think about it a little bit. In systole, when the LV is contracted, blood is flowing from the pulmonary vein into the left atrium. When the left ventricle is relaxing in diastole, blood is still flowing from the pulmonary veins into the left atrium. But when the atrium contracts, when the left atrium contracts, it's going to force blood in the opposite direction. Because remember, the pulmonary vein is draining into the left atrium. But when the left atrium itself contracts, it's going to force blood in the opposite direction in the pulmonary vein. And that is why you get an atrial reversal, because your probe is right there. If the left atrium is contracting, then blood is going to go in the opposite direction, away from the transducer. So your atrial flow reversal is going to be below the baseline, because now the blood is forced back into the pulmonary vein, which is moving away from the transducer. So your atrial flow reversal is below the baseline. Okay, and in a normal pulmonary vein flow, the systolic component is greater than the diastolic component in a normal flow. Okay? Again, tricuspid inflow. So you need to know all the velocities that you're going to measure using pulse wave Doppler. So for tricuspid inflow, apical four-chamber view, it, tricuspid is on the right side. This is your right atrium, right ventricle. Blood is going to flow from the right atrium across the tricuspid valve into the right ventricle. It's going to move towards the transducer. So it's going to be above the baseline. Okay. And it's going to be in diastole. Tricuspid inflow is in diastole. And again, you're going to have an E velocity and an A velocity. Okay. You're going to have an E velocity and an A velocity. And similarly to the left side, your E velocity is rapid flow, okay, the suction of blood from the right atrium into the right ventricle as soon as the tricuspid valve opens. Then you will have a diastasis, then the atrium contracts, and you get your A velocity. So you have your E velocity and your A velocity, but it's on the right side. Okay, so pulse wave Doppler, it is limited by its inability to measure high blood flow velocities. We were saying that over and over. The limitation of pulse wave Doppler, it can only measure velocities which are up to a certain measurement. Low velocity, usually less than 2 meters per second. Anything above 2 meters per second, you get what we call aliasing. Aliasing will occur at velocities above 1.5 to 2 meters per second. And what aliasing means is that if you're measuring a velocity of, say, 3 meters per second, once it gets to 2 meter, it's going to cut off the 2 meter. It's going to put the 2 meter, say, on top and then 1 meter below. That is what aliasing means. So aliasing is represented on the spectral trace as a cutoff of a given velocity. And this is what we mean. So you're measuring TR. This is this is AI. This is aortic insufficiency. And this aortic insufficiency might be, I think it was 3 meters. So when it gets to 2 meter, it leaves 2 meter on top and it put the other meter below. Okay, so once you see this, you know that's aliasing. If you switch now from your pulse wave to say continuous wave Doppler, then it puts everything on top. So when you're measuring high velocity flow, you need to move from pulse wave Doppler to say continuous wave Doppler. The limitation of pulse wave Doppler, it can only measure low velocity flow, 1.5 to 2 meters per second. Anything above that, you have to move on to continuous wave Doppler. So we're gonna stop here, and our next session we'll look at continuous wave Doppler and color flow Doppler. But Doppler is extremely important. A complete knowledge of Doppler is important for you to move forward because majority of echo is Doppler. We use echo to look at regurgitant lesions, and you have to measure sometimes gradients, that is pressure difference. We have to measure valve areas. So once we're talking about any calculation in echo, we're talking about the Doppler principle. And majority of what we do in echo is Doppler. So a thorough understanding of Doppler is crucial. All right, so we're going to stop here.